Hello, this is Erin Harper-Sanchez. I'm talking about the case study for this week. This is about Midge, a 72-year-old female who lives with her daughter in a rural southern Appalachia. Um, Currently, she lives with her daughter and then three of her great-grandchildren whose parents have lost custody. Um, there has been recent changes in Midge's cognition and changes in behavior. So we're going to talk a little bit more about that. Starting off with the social determinants of health. So there's few aspects that are considered core components of this. That includes economic stability, neighborhood and physical environment, education, food, community, and social context and healthcare systems. So as far as these aspects, how they are kind of impacting Midge's care, first of all, the economic stability. She is currently retired and relying on her daughter to care for her along with the three great-grandchildren. So it sounds like her daughter is under a lot of stress and not sure how much money she is bringing in, but that's, currently five people on one person's income. It also isn't sure if Midge has Social Security or if she's enrolled, I'm assuming, in Medicare. So there is some concerns there. Neighborhood and physical environment. It is noted that, like she said, she lives in a rural community. This is usually there's limited public transportation, parks, playgrounds, and walkability. Living in a rural community can also lead to limited access to healthcare with less provider availability, and this can impact her quality of healthcare just because there is less available. It is known rural Americans are more likely to die prematurely from the leading causes of death in the U.S., and they include heart disease, cancer, lung disease, and stroke. Rural Americans also have higher rates of obesity and diabetes. There's also at a greater risk of fatal car crashes, suicide, and drug overdoses. So those are also things that impact living in a rural community. There's also some potentials with the healthcare systems. In addition, because she is potentially on Medicare, so that can limit who will see her, unless she has private insurance. There can be a potential bias due to her age. As far as like social support, her interactions is limited to her family, so her daughter and three grandchildren. Living in a rural community also can limit the community engagement due to, kind of living distantly from other people. As far as her education is limited due to her leaving school at age 15, and does not say that she had any higher education or vocational training. As far as the determinant of health with food, like I said, it is one person's income for five different individuals, and uncertain if they have enough to eat. What is the nutritional value of the food? It is also known in rural communities because of the obesity increase. Usually the foods have been shown to have higher sugar content, higher fat content, just because of the again, limited access to grocery stores and such. The developmental theorist I used was Erickson. So an older adult, 65 and older, the integrity versus despair. So Midge may be experiencing despair that could be influenced by her current medical condition and state that makes it difficult for her to maintain a consistent sense of self, leads to struggle between the sense of integrity and the feelings of despair. Her medical conditions could compromise her ego's ability to maintain the sense of self, making her increasingly dependent on others for support, like her daughter. This dependence can lead to confusion and struggle to maintain consistent behaviors. The despair could be due to missed opportunities and abilities, and this could have stemmed from her having to leave school at the age of 15 and not being able to go on to higher education or vocational training. It's hard. She may also be experiencing some of the regret that is manifesting as fear, potentially anxiety, depression, things that we'll talk about later. As a provider, it's important to help her by focusing on helping to preserve her current abilities, support the remaining um, of herself, and improve her quality of life. So based on Midge's presentation, there's several different diagnoses. So definitely, I believe she has a major neurocognitive disorder or dementia. That's kind of divided up into Alzheimer's, frontal temporal, Lewy body, or vascular. So for all of these, there is significant cognitive decline from her previous level of performance in one of the more of the cognitive domains. So her daughter is telling us that she used to be able to like care for the grandchildren or great grandchildren, and now there's difficulty in doing that. So some of the cognitive domains she's kind of seems to be affected are complex attention, so being able to do multiple things at one time, executive function, learning, memory, and potentially some social cognition. And these do interfere with her ability to be independent in her everyday activities. That's what her daughter is upset about, is that having to kind of come home from work and manage these things. So the diagnosis I'm using for her is going to be vascular dementia. So what I believe is due to her diagnosis of chronic hypertension and not being taking her medications. There's a disruption of blood flow to the brain, and there is causing a cognitive impairment. As I will talk about later, there's more testing that needs to be done to kind of clarify exactly what the impact has been. For her, there is evidence for the decline is prominent in, like I said, her attention, executive functioning. These symptoms, it's hard to know how long this is going on, but it's been going on, it sounds like, for a while. And so can have some difficulty with her memory loss, difficulty with thinking, potentially mood changes. It says that, in her situation, hallucinations or delusions can occur depending on the location and severity of the brain damage. Like we'll talk a little bit more as far as what additional testing we need to kind of clarify that aspect. Some other ones that we would kind of differentials are Alzheimer's. For Alzheimer's, she does not have a known genetic mutation. There is, a decline in memory and learning. But like I said, she has potentially a cerebral vascular disease with the chronic hypertension, so that could be impacting her behavior. Frontal temporal, these disturbances, changes in her social behavior, which has not been apparent. No language impairment, so no decline of expressive language or word comprehension, not any major dietary changes. She has not noticed that there has not been any kind of mention of motor function changes. And again, there's no mention of genetic mutation. That would kind of lead us to that. I mean, she does have, again, some of the, decline in social cognition and executive abilities. Also, in frontal temporal, they're saying there can be sparing of learning and memory, which she definitely has, so that would not be correct. Another area of major neurocognitive disorders or dementias is Lewy body. So this disturbances with Lewy body, these can also kind of have difficulty in planning, organizing. She has an inability to concentrate potentially and is disorganized, but she doesn't have any of the movement problems that can be like muscle rigidity, tremors, loss of coordination, reduced facial expression, or as they say, some like Parkinsonianism. They do not mention any gait imbalances. Yes, she does have visual hallucinations, but like I said, that can be in other, potential diseases as well. Does not mention any kind of sleep disorders. We don't hear about insomnia or excessive daytime sleepiness. The other thing is with Lewy body, that's usually 50 and older. Going back to vascular, that's over 65, which she's 72. Frontal temporal is 45 to 65. And then the Alzheimer's is mid-60s and above. So again, also kind of leading as far as these different forms of major neurocognitive disorders or dementia, leading that this is most likely a vascular component. Some other differentials could include delirium. Um, Again, she does have some disturbance in attention, reduced ability to direct focus, sustain, and shift attention. But it does not sound like this has been a short-term situation. And delirium usually is a short-term. And it says that with delirium, it can fluctuate during the day. It does not sound like her behavior changes depending on the time of day. And delirium can be temporary and fluctuate, which again we're not seeing. Another differential is brief psychotic disorder. Like I said, she does have hallucinations, potentially delusions, but does not have disorganized speech or behavior. And again, I believe this has been going on longer than the time frame, which for a brief psychotic disorder is greater than a week, but less than a month. The schizophrenia is another differential. She does not have a previous diagnosis of schizophrenia. So she has had delusions and hallucinations, but again, no disorganized speech or behavior, no negative symptoms of that we know of schizophrenia. And even though this could be going on for a month, it says continuous signs of disturbance for 6 months. There's no mention of it, like I said, a time frame, so I'm not sure of that. Another kind of differential is bipolar, and again, no previous mention of diagnosis. She has no history of any other psychiatric diagnosis, and not experienced, sounds like episodes of mania or hypomania or depression. Another one is depression with psychotic features. I mean, again, there is vivid hallucinations and delusions. Again, no history mentioned of depression. And she does not seem to have any of the symptoms of depression, including like diminished interest in activities, weight loss, insomnia, hypersomnia, psychomonia, agitation, fatigue, loss of energy, feelings of worthlessness, recurrent thoughts of death. And another differential is acute stress disorder. Yes, it sounds like, she is maybe having a little bit of fear anxiety with this hallucinations, but there's no dissociative symptoms and no that we know of recent severely traumatic event. Some of the different screening tools we can use are the mini mental status exam. Again, this is reputable, widely used, 11-question test that assesses memory, orientation, attention, and language. The MOCA, which is the Montreal Cognitive Assessment, is also a valid test. 30-question test that covers a broad range of cognitive function, executive function, visual spatial abilities. The St. Louis University mental status exams, or the SLUMS, shorter 11-item test that focuses on memory, attention, and orientation. One of the components of the SLUMS is the clock drawing test, which kind of like draws into that, and that can reveal problems with visual spatial abilities and planning. The SAGE, or the self-administered gyrocognitive examination, is another screening test, 15-question test that assesses memory, language, and executive function. When we're kind of trying to differentiate the different types of dementia, the Haseki ischemic scale, this can help with deciding between Alzheimer's and vascular dementia. So when we're deciding on her diagnosis as vascular dementia, we'll start with the non-pharmacological treatments. Like with any condition, the main treatment or the main goal is the cognitive behavioral therapy, or CBT. So we know that CBT empowers individuals to challenge negative thoughts, patterns, cope with stressors, enhance psychological resistance, thereby strengthening cognitive well-being in aging populations. And they're showing that it may improve memory, attention, and problem-solving skills. Some of the other things could be mindfulness, that includes meditation, yoga. This is more evidence that it can also help mitigate cognitive decline by reducing stress, enhancing attention control, fostering neuroplasticity in areas that are implicated in cognitive processing. Some other things with any form of dementia is reality orientation. So providing information about current time, place, and events to reduce confusion. Environmental modifications. This could be adapting the home environment to support cognitive function using clear signage, color coding, decluttering, making it easier for them to move around, know where things are. Some other options are music therapy. This can help reduce agitation, improve mood, promote relaxation. Occupational therapy. This is engaging in activities that promote daily living skills, such as cooking, gardening, and crafting. So just kind of reutilizing skills so that they don't lose them, or kind of help them build on what they already have. Again, exercise, of course, regular physical exercise, we know improves cognitive functioning, reduces stress, and enhances overall health. Some dietary interventions may be like Mediterranean diet with a plant-rich diet and fruits, vegetables, whole grains, and fish. That's been shown to slow cognitive decline. Taking or eating foods that have high in omega-3 fatty acids may improve memory and brain function. Vitamin B6 has been reported to enhance cognitive function, particularly in vascular dementia. These are other kind of interventions, ultrasound therapy and non-invasive treatment that uses sound waves to stimulate brain activity and improve cognitive function. Pet therapy, interacting with animals can provide companionship, reduce stress, and improve mood. Support groups, again, connecting, that's what she would really benefit from if there was connecting with other individuals with dementia, supporting emotional and information sharing. So moving on to pharmacological treatment. So for vascular dementia, there's no current standard treatment. Really, what the point is, she needs to kind of restart her antihypertensives and any other medications that may help her vascularity. So if she has high cholesterol, diabetes, and not smoking. Cholinergic dysfunction has been documented in vascular dementia, and so these patients may benefit from central cholinergic system restoration. So they can be used for symptomatic treatment and the most common ones are the donepezil and rivaroxaban. They've actually been shown both to be effective at improving cognition with dementia and are recommended as first-line treatments. So depending on what other symptoms she's having, if she's having depression, SSRIs, the ones like sertraline or Prozac can help and be useful because they have fewer anticholinergic side effects. And this can be helpful with people with dementia, sometimes have depression or anxiety, and those symptoms can manifest themselves with agitation and outbursts. So those are things to kind of think about. She is not exhibiting it at this time, so may not be needed. As far as addressing her hallucinations, so I think as a provider, we need to know that hallucinations may not always need to be treated. So hallucinations that are kind of neutral or comforting or pleasurable, which she seems to not, be a little irritated, but also engaging in, do not need to be treated. The risk, usually the treatment includes an antipsychotic, and so what's hard is, again, you have to balance risk-benefit. So really antipsychotics should only be used if there's a safety risk. So if they're really stressful for the patient, if they're having agitation, aggression, then they should be used. But it's just hard. You really have to be aware of the risks and side effects, such as higher mortality due to risk of cardiovascular events, which again, she already has we know of chronic hypertension, high risk of falls, and EPMS symptoms. So the big thing too, to kind of wrap it up, is patient education. So really, we need to educate her and her daughter about what vascular dementia is, and knowing that this is caused by a reduced blood flow to the brain. And so because of her history of chronic hypertension, she may have small vessel disease, and so her brain may already have some impact, and we don't know if she's had a stroke or not. Again, this progression can be sudden or progressive, just depends. If she had a stroke and we don't know about, then this could have happened quickly. And we talked about the symptoms of being like memory loss, confusion, difficulty with planning, changes in potentially mood, the hallucinations. And so really what we need to do is get her to get further evaluation, particularly with her primary care. And this could make sure it includes a physical exam, cognitive assessment, all the things we talked about. Evaluations, is she able to do her activities of daily living by herself, and now managing the care of the great-grandchildren. Would want to have her do some blood work that would include a CBC, CMP, thyroid, vitamin, checking for vitamin deficiencies, anemia. For her, like we're talking about vascular, is brain imaging, like an MRI or CT scan, because we need to know, did she have a stroke? What is going on? Is she have plaques? We need more. The thing is, we also need to talk with them about, medical management. Like I said, there's no one treatment. She just needs to really restart it on her antihypertensive. So we need to prevent further vascular damage and manage her symptoms. So she needs to also kind of like not stop anything without telling us, report side effects, monitor her chronic conditions. So like her blood pressure needs to be closely watched. And then, like I said, this blood work, so we know if like screening for diabetes and if her cholesterol is fine. The lifestyle modifications, really, we need to talk with her and her daughter about, healthy diet, which, low in salt, low in saturated fats, high fruits and vegetables and whole grains, making sure she's hydrated. Talk about being physically active, make sure avoiding smoking and alcohol, and make sure she's having a healthy weight. With her daughter, we just really want to make sure that the environment is safe too. Like we talked about, preventing falls and accidents, keeping walkways clear, good lighting, removal of rugs and clutter, potentially grab bars in the bathroom, all medications organized. We need to talk about whether she can drive, if she can be driving her great-grandchildren to school or activities, and always have some emergency planning. So the daughter and her need to have some emergency contact numbers and medical information. Really the other thing is knowing, like having her daughter know, like she still needs to be stimulated with, using puzzles, reading, music, things like that can help her, and then maintaining a structure to avoid confusion. Some communication tips like speaking slowly and clearly, using visual cues, and then her daughter really needs to monitor her depression, anxiety, and allow her to increase, her activities into social situations. Sorry that was long, but thank you for listening and have a good evening.